finding it probably can affect the heart muscle, and it can affect the lining of the coronary arteries. It hasn't been studied enough to come out with a definitive statement, but probably COVID can cause heart failure down the road. Yeah, it's a viral illness, and viral illnesses are one of the things that can cause heart failure in the long term. Any viral illness. But we know COVID definitely does have an effect on the heart. We know that for sure. We just don't know if it for sure causes heart failure down the road.
I will share, I had a rowing coach who just had a heart transplant in COVID, and he had a snake bite induced heart failure, basically.
Oh, from the venom.
Yeah.
Wow. Yeah.
When he was 30 something, he got bitten by a rattlesnake and had a prolonged hospitalization.
Oh.
And, you know, 15 years later, his heart was just
from the venom. Interesting. So why are we talking about this today? The whole idea always with everything we talk about here is to make a difference and allow you all to make a difference. So the recent theme for heart failure, there's always a heart failure awareness week every year. There's a Heart Failure Nurses Association and Physician Association. And this year their theme was to detect the undetected patients. Because if you're going along with just the beginning symptoms of heart failure, but you don't know you have it, then nobody can intervene. Or if you currently have heart failure, but you're not on the right treatments for it, and you're just going along, less likely that you're going to have an improvement in your ejection fraction, or less likely to have less hospitalizations and those sorts of things. So detect the undetected. So intervening early can make a big difference in people's lives and how long you live. Once diagnosed with heart failure, your chance of dying within 5 years is 50%. Now, that sounds very dramatic. That's if you're not getting treatment, if you're not getting treatment. So with detection and treatment, you can stop it. You can just stop it in its tracks. We have new medicines now. I was just talking about that, and Linda will give you the names of some of the new ones. Definitely slow it down so that 5-year thing is more like 10, 15, 20 years. And if you don't have heart failure, of course, we want to prevent it. So that's why we're talking about this today. So just to give you, I'm not going to go into a lot of detail about this, but there are 2 main types of heart failure that you might hear your physicians talk about. The first one is called, if you see those letters up there, the doctor might say it's called HFrEF. You see how it says HFrEF? They say HFrEF. So it's heart failure with reduced ejection fraction. So it's also sometimes called systolic heart failure, but we're getting away from calling it that anymore. So you'll hear it HFrEF, or heart failure with reduced ejection fraction. And that just means your ejection fraction is 40% or less. So what's an ejection fraction? Anybody know?
How much blood is pumped out
With each beat.
with each beat?
Right? So a normal ejection fraction would be, greater than 50%, certainly, but more like 60%, 65% is a normal ejection fraction. So that indicates that not all the blood gets pumped out with each beat, right? If only 65% gets pumped out, and that's normal, there's a certain amount that's 35% that's staying in the heart. There needs to be a certain amount of blood that stays in the heart even after it pumps in order to keep the heart inflated. It'd be like when you take all the blood out of something or fluid out of something, kind of like that. So you don't want your heart to deflate. So there's always some blood that stays in the heart. So a normal ejection fraction is not 100%. It's more like around 60%, 55%, 65%. So this is heart failure with reduced ejection fraction. Take a look at this heart compared to what we call the normal heart. What difference do you see in the muscle wall there? Thinner, right? Much thinner. Everybody see that? So in heart failure with reduced ejection fraction, the muscle gets thinned out. If a muscle gets thinned out, it's kind of like a rubber band that got stretched out and then it loses its elasticity, right? If you take a rubber band, you stick it around a tennis ball and leave it there for a year, take it off, it's just not going to be able to contract as well. So that's what happens in heart failure with reduced ejection fraction. The wall gets thinned out, doesn't squeeze as well. So the other type of heart failure, main type, is called heart failure with preserved ejection fraction, also called HFpEF, you might hear healthcare providers talk about. And that type of heart failure your ejection fraction, you can see up there is 50% or higher. So pretty much, more like a normal ejection fraction. But what happens is the wall here is also looking different, isn't it? What's the difference in the wall there, the heart wall? Thicker, right? It's thicker. So in HFpEF, the heart has not lost its ability to squeeze, but it's gotten stiff. And so when it tries to fill with blood, instead of being able to relax all the way like that to fill with blood and get a lot of blood in there, it's stiff. So it only relaxes like that. If it only can relax that much, then not as much blood can get in there, right? And if not as much blood gets in there, even though the heart's squeezing normally, not as much blood goes out. So in both cases, either because your heart's not squeezing well or it's not relaxing well, the end result is that not as much blood gets pumped out. If not as much blood gets pumped out, then your muscles are not getting as much blood, your brain doesn't get as much blood, your kidneys don't get as much blood. And that's why it's called heart failure, is because your heart is not pumping as effectively as it used to. Does that kind of make sense? Okay. All right.
So.
yeah.
I'm just intrigued by the diastolic or the HFpEF.
Yeah.
Because obviously it's less blood, but how do they measure that? How do they diagnose this?
Oh, good question. Yeah. So how do you know what your ejection fraction is? How do you know if you have this? So in order to be diagnosed with heart failure, number one, you have to have symptoms, and I have a slide coming up that'll show you some of the symptoms. And you have to have some what they call structural changes in your heart. And you can see those on an echocardiogram. Probably, has anybody here not had an echo? An echocardiogram. You can see, what the muscle walls look like. You can see what the ejection fraction is. There's other tests that also measure the ejection fraction, like certain thallium tests. A heart catheterization would measure your ejection fraction. Okay, so we want to know whether you have heart failure currently or you want to prevent getting heart failure. It's important to know what the causes are, right? So the most common two causes I put right at the top there, having a heart attack or having blockages in your coronary arteries is one of the number one causes of heart failure, or having your heart not be able to pump effectively. And the second one is having high blood pressure. We're going to talk a little bit more about high blood pressure in one of the future slides. So you can imagine if your heart's here, it's got coronary arteries that bring blood and oxygen to it. If those coronary arteries were to get blocked off, then there's going to be a portion of your heart that's not getting blood. And you can develop, if you have a heart attack, you actually get scar tissue there. So you've got a part of the muscle that's just not able to contract and do well. So you can see how that could cause heart failure. Having high blood pressure, when your heart has to pump, when you have high blood pressure, the pressure out, here's your heart, here's outside your heart, blood vessels. When you have high blood pressure, the heart has to pump harder in order to press against this higher pressure that's outside the heart. So that over time releases chemicals and causes changes in the inside lining of your arteries and causes heart failure. Heart valve diseases, so things like, your aortic valve, all the valves that sit around your heart. So the aortic valve, the mitral valve, the tricuspid valve. Problems with those where the blood's either being stopped from going out or regurgitating back can over time. None of these things are sudden except for a heart attack, but none of the other things are sudden. So over time, if you have valve problems, that can contribute to your heart developing heart failure. Genetic cardiomyopathy. So that just means you have a genetic predisposition to an enlargement or changes in that heart wall. So if there's a certain, I forget what it's called, but it's like a certain number on the gene that causes you to be more likely to have this happen. Endocrine problems, having diabetes makes you more likely to develop heart failure in the future. Having hyper or hypothyroidism that's not under good control. Arrhythmias. Have any of you heard of atrial fibrillation? Yeah. Or SVT, supraventricular tachycardia. That's where your heart just kind of beats along quickly. You can have runs of it. So these things, as you can imagine, if your heart's both with atrial fibrillation and SVT, which atrial fibrillation is a type of SVT. But in both of those situations, you can imagine that your heart's beating along faster. That's putting more strain on your heart. Also with atrial fibrillation, because it's irregular, it's instead of going lub dub, it's going lub lub dub, lub lub dub dub, lub dub, you know, that kind of thing. The amount of blood that pumps out is less because your heart's just not pumping synchronously and effectively. So over time, those can cause heart failure. We already talked a little bit about viral infections because they cause an inflammatory response in the body. We've known for years that certain viruses, sometimes people come in and they have heart failure and there's no apparent reason. They haven't had high blood pressure. They don't have any blockages in their coronary arteries. They don't have a genetic predisposition. They're not taking any illicit drugs. They don't have diabetes. They're active. They're, you know, a good diet. Their cholesterol is not high. The doctor will always ask, have you recently had a viral illness? You know, have you been sick with a flu, with a cough, any kind of thing like that? And now they'll ask you about COVID. You can also develop heart enlargement during pregnancies. That's what a pericardium cardiomyopathy is. Sometimes those will go away after the pregnancy, but sometimes they'll not go completely away, but improve. And toxins. Toxins are things like alcohol. I'll talk a little bit more about that. Chemotherapy. It's important if you're having if you have cancer or you're undergoing chemotherapy or radiation to let your cardiologist know, because sometimes, especially with some of the chemotherapeutic agents, they will actually put you on a little bit of a preventative drug because we know that some of the chemotherapeutic agents can definitely cause heart failure. So as a prevention, they put you on a beta blocker in order to maybe stop that from happening, at least lower the chances of it happening. Smoking directly causes an inflammatory state in the heart and can affect heart failure. Illicit drugs such as cocaine, methamphetamine. When I was working in the hospital with the heart failure patients, you know, I never used to see patients that were young, that were in their 20s and 30s coming in with heart failure. But now we see it because of the methamphetamine epidemic. It's a stimulant to the heart. The heart just gets completely inflamed and overloaded. Got a lot of epinephrine, all the stress hormones. Methamphetamine's like just having stress hormones going to your heart all the time. Same with cocaine. So, and that's ongoing right now. So it's a horrible thing. Radiation. Being in the obesity category, having a BMI of 30 or higher, puts you at higher risk for heart failure. Having obstructive sleep apnea. So, you know, you can get tested for if somebody tells you you're breathing oddly at night, if you're finding during the day that you're just tired all the time. I know a lot of us are tired all the time, but being tired all the time, falling asleep during the day, those kinds of things, it's good to get that checked because having sleep apnea in and of itself can cause heart failure. Smoking, vaping, risk of heart failure is increased by 47% from this. And then, you know, there's still things that are unknown that cause heart failure. So this is important to know because if you have heart failure, you want to make sure that none of these things are not under good control. So if you have AFib, you want to make sure that you're on the right medications to slow the rate down, do what you can to take the right medicines that sometimes can stop the AFib. If you get your blood pressure under good control, get your diabetes under good control, have your weight be under a healthy weight, all those things. So this is an important slide. These are called the stages of heart failure. So they divide it into 4 stages. And I just wanted to point out, they now categorize stage A as being heart failure. You know, there used to be a little thing on there where I could zoom in. I don't know.
I don't think
it's not on there. Okay. Anyway, I don't know if you can see it or not, but I'll tell you what it says. So stage A is really interesting because it says stage A is people who are at risk without structural heart disease or symptoms of heart failure. So there's no changes yet that like I showed you on the slide with the HFpEF and the HFrEF. Those wall changes haven't occurred. You're not having any symptoms. You're not short of breath. You're not retaining fluid. None of those things. But you do have risk factors for getting heart failure. So you may have diabetes, you may be overweight, you may have metabolic syndrome, which is a combination of things, having high triglycerides, having high cholesterol, having low of your good cholesterol, having blood sugar that's not under good control. You don't have diabetes yet, but when they measure your blood sugar, it's in the high range, or your hemoglobin A1C is in the high range. Having high blood pressure. So people with high blood pressure, maybe they've done a cath and they can see you have a little bit of blockage in one artery, but it's not enough to put a stent in it yet. It's not causing any damage yet to your heart, but it's there. Having diabetes, having obesity, and having metabolic syndrome. Those things all put you, they call you're in stage A of heart failure. So any of us that have any of those things, we really have to, wave a red flag. I got to look at this and get these things under good control, because that's the time when, you haven't had any structural damage yet. So that's when you really want to make the changes. So it's good to know, ask your doctors about this. Do I have metabolic syndrome? Those kinds of things. Okay. And then stage B, is where you have structural heart disease, but you don't have symptoms yet. And then stage C is when you have the symptoms. These are most of the patients that I saw when I was working with patients in the hospital with heart failure, getting admitted with heart failure. They have symptoms, we're adjusting medications, those sorts of things. And then stage D heart failure is when you're needing a heart transplant or some sort of assist device to help your heart pump. So lots you can do at all these different stages to slow the progression, to stop it right where it is, or if you don't have it, to prevent it.
So 65 million people are already at stage C, right? Because they're symptomatic. And
Yes,
well
that's right.
diagnosed.
That's right. Yeah. So how does heart failure happen? So I made up this little diagram. So the first thing that happens in order for heart failure to get started is, and like I said, it doesn't happen overnight, it's a process, is that there's some sort of insult to the heart or something that is causing the heart to get stressed from usually chronically stressed. So what are some of the things that we've already talked about that could be considered an insult to the heart? I've got some of them listed up there if you want to cheat. Well, heart murmur, that's a good point, can indicate that you have problems with one of your valves, right? So absolutely. So
Branch block.
a what?
Bundle branch block.
Oh, bundle branch block. I don't know about that one.
We're just gonna find another way.
I think, yeah, and I think a bundle branch, it depends on the type of bundle branch block, because some of them can cause more heart damage than others. So good point though, yes. Some sort of electrical problem with the heart, such as atrial fib also.
My brother-in-law went in for a gallbladder removal and woke up and he had a pacemaker because they had irregular heartbeats.
Yeah.
from surgery.
Yeah,
And so that was quite a shock to him. No pun intended. So sometimes something like that.
it's a good point. I put up arrhythmias as one of the causes of heart failure, and most of the time we don't know if we're having an arrhythmia, right? I love these smartwatches now because, I have had AFib in the past, and this watch, I can set it to tell me if I'm having atrial fibrillation. Now, because not everybody, I can feel when I have atrial fibrillation, but a lot of people don't feel it. And you don't feel if you're having a supraventricular tachycardia all the time. So, and he didn't know.
Yeah, a lot of people more.
And we think, well, sometimes, fast heart rates can just make you feel like you're anxious. And so I've had a lot of patients that, came in and they came into cardiac rehab and they said, well, I need to work on my anxiety because I'm feeling short of breath and I'm feeling stressed all the time. I had one patient, it turned out they were having a heart rate of 160 intermittently throughout the day. They had an arrhythmia and nobody knew, So lots of times we don't know. So your brother found out because the anesthesiologist was monitoring him during surgery.
I also had a friend who went to the dentist and his blood pressure was so high that he called an ambulance.
Oh.
He had bags of heart issues.
Yeah.
So.
Right, so I think, trying to be as aware as we can, and if we're feeling something's not right, don't always say, oh, it's because I'm getting older, or, I've been under stress, get it checked out, because, you want to intervene early, right? Want to find out early. Were you gonna add something, or were you just, I thought I saw your hand up. No? No, okay. All right, so something happens to the heart. It causes, when some sort of insult like atrial fibrillation, high blood pressure happens, it causes chemicals over time to be released. And most of these chemicals are things that cause an inflammation in the heart. And this is the renin aldosterone angiotensin system. It's really just your stress response. It'd be like if a tiger was chasing you all the time. These stress hormones that cause your heart to go faster, your blood pressure to go up, and it allows you to respond, get across the street really fast if a car is going to hit you. But you don't, and you do want that if a tiger's chasing you or if a car is going to hit you, but you don't want to be running around all day with these kind of chemicals just hitting your heart. So that's what happens when there's these insults to the heart, when you have high blood pressure, atrial fibrillation, a valve problem. It causes these chemicals to be released. Once these chemicals are just kind of being released all the time, that's what causes that remodeling of the heart. The remodeling of the heart is what I showed you earlier, where the heart wall's either getting thinner or it's getting thicker, but either way, the heart just can't pump well. So once the remodeling has occurred, you get progressive worsening of the heart function. And then that's when you begin to get the symptoms of heart failure: shortness of breath, swelling, tiredness, memory problems, weight gain, that sort of thing. So that's kind of the trajectory of heart failure. So I just thought I'd put this up. These are some warning signs of heart failure. Sudden weight gain, unless it's Christmas time or Thanksgiving. But, especially around Christmas time and Thanksgiving, people with heart failure can gain weight because there's so much salt in the food. So you will see a weight gain, but sudden weight gain of usually, 3 pounds overnight can be an indication of that. Increased coughing, swelling, more fatigue all the time. That doesn't go away. Of course, we're all going to be fatigued sometimes. It doesn't go away. This is kind of a big one, increased shortness of breath with activity. You should be a little short of breath when you're in here exercising, right? But it's a different kind of shortness of breath. It takes longer to recover. You kind of can get it with mild activities. It's different than when you're walking on a treadmill or using a new step. Increased number of pillows at night in order to breathe well. So if you find that you're having to usually sleep with one pillow, and you're having to use 2 or 3 pillows in order to breathe well at night or to feel comfortable, that can be a big indication of heart failure, because it's an indication that you're getting fluid overloaded. So that's a good time to ask your healthcare provider about that. Having a bloating sensation, like sometimes when with heart failure, when you have structural heart failure, you retain fluid, and you retain fluid in your stomach, in your ankles, in your hands, in your breasts, everywhere. So just be aware of fluid, and it can come and go. New sensation of an irregular heartbeat. Sometimes being fluid overloaded in and of itself can cause you to have an irregular heartbeat. So always go get that checked out if you have that. Having chest pain or discomfort, waking up in the middle of the night, short of breath, needing to use more oxygen. If you normally use oxygen, but you're having to up the liters, that can be an indication of heart failure. So any questions about those?
Yeah, it's in hospital, and as time went by, after that, eventually I was short of breath. I didn't have any pain.
Yeah.
But when I was running to and fro and helping the members there at my work, after I was done lifting something or loading something for them, I went to the hospital.
Yeah.
I'd be walking back, and I was stuck to feel this finding shortness of breath.
Yeah, it's different than your normal shortness of breath.
But it got depressed.
Uh-huh.
And then the weight gain and
the
fatigue and sleeping, everything just like dominated.
How long did it take you before you kind of figured out I need to have somebody
Well,
take a look at me.
I honestly, between 5 and 6 months, and the reason being,
That's not unusual.
you know, I was like, well, you know, I feel, I feel okay.
Yeah.
And this is just coming on, I go, is it lung cancer, or I didn't ever think of my heart,
Sometimes people will think, oh, it's just allergies.
or something like that.
Right, my chest feels full, I'm more short of breath, but it's going away. Yeah,
But I had a unfortunate experience with the family doctor, former family doctor that I had, and we misdiagnosed, because what happened was, when I did go to see him, he goes, well, we're not gonna test you for your heart. He goes, we have heart checkup, full blow, in 2009, and this was 2015. So,
6 years later.
he goes, I'm not gonna waste any more. But what I'm gonna do is I'm gonna schedule you for an upper GI, because I think you probably have, because I had the indigestion,
Yeah.
the heartburn and all that.
Yeah.
For upper GI, or you have a hernia,
hmm
possible hernia. So this went on, and I went back probably at least 3 times. And I said, this is not a hernia, he goes, look, we're gonna do this test. Just, sit tight, and we'll get it all figured out. I go, what am I supposed to do? No, I got people at work that was literally screaming at me to go to the ER.
yeah,
And which I should have. So 2 days away from the upper GI, I went in that Sunday, July 15th, 9:23. I collapsed.
Yeah.
I was working. I got up to about maybe an hour and 10 minutes, and then that feeling of
yeah,
pressure,
yeah.
and then the burn, and then
Yeah.
horrible heart attack came on.
Yeah.
And it was like hanging on for the rest of the day. I got
So did you get your upper GI workup and while you were?
oh, you talk about wanting to strangle somebody.
Yeah.
I did see him one time after I recuperated, and after he found out what had happened. And I could have been truthfully obnoxious and thrown the book at him. I did not. I had grace. I bit my tongue, but I tell you what, I said, me and my wife, we just sat there and we looked at, he knew.
Yeah.
He knew.
Yeah, he should have said something to you, I would think.
He didn't even.
Well, thanks for sharing that story, because it's not uncommon, we have to advocate for ourselves, right? You have to trust your gut.
Yeah.
You knew something was different. Yeah. Thanks for sharing that. So now that we've talked about all this negative stuff, how to slow the progress or reverse heart failure. So you can intervene, and if you have heart failure already, you can intervene in 3 different spots, right? You can intervene at the very top. So if you know, or your doctor, you've talked with your doctor and you know what's caused your heart failure, and it's something that can be managed better, then you work right there. You get your blood pressure under control, you lose weight, you get your cholesterol under control, you quit smoking, all the things we talked about. So you want to, get those under control. So you want to, if you have heart failure, you want to talk to your doctor and find out what the cause or causes are of your heart failure, and make sure that those are doing well. Your blood sugar is good, all those things. You can also take medicines now. We have a number of medicines that help reverse the muscle changes to the heart. So for heart failure with reduced ejection fraction, that thinning kind of heart failure, there are a couple medicines. Well, there's four medicines really, beta blockers and ACE, I don't have a whole thing on the meds, but beta blockers, ACE inhibitors, and then there's these aldosterone antagonists, and then there's new medicines out now, these SGLT2 inhibitors. So yes.
Could you explain beta blockers?
Well, for heart failure, well, they just cause the heartbeat to slow down, and when the heartbeat slows down, it has more time to fill with blood, and so then the cardiac output is greater. You can be on a beta blocker. It's one of the primary medicines that's recommended if you have heart failure, but it's also one of the medicines that you can be on if you have other things, like if you have high blood pressure, you could be on a beta blocker. If you have certain kinds of arrhythmias, you might be on a beta blocker. And sometimes, remember when I talked about the chemotherapeutic agents causing heart failure? Sometimes they know so much that that certain one will cause heart failure that they might put somebody on a little bit of a beta blocker as a prevention for heart failure, developing heart failure.
Joe
So-
has a question.
Yes.
Difference between an alpha blocker and beta blocker.
Well, the alpha blockers also work on the heart. The beta blockers are the ones that we use for heart failure. Yeah. They just work in different ways, but the beta blockers are the ones you won't hear about an alpha blocker for heart failure.
So the alpha and the beta, those are referring to the receptor sites. So the beta blocker is acting on the beta receptors in your autonomic nervous system and doing its action by that. So I don't know what your alpha receptors are, but you must have them if they wouldn't have an alpha blocker.
Was there another question over here?
Yeah, I think, what about blood flow regurgitation? In the.
From the valve, yes.
Yeah.
So would you know which valve?
No.
So
I mean,
there's
I know.
There's an aortic valve.
It's documented, but I don't.
So in any case, if there's regurgitation, so the blood is supposed to go forward.
Yeah,
So
I
if
understand.
it comes back, then that puts more strain on the heart. The heart, that chamber that it comes back into,
Right.
over time gets overloaded. It's always having to compensate for this increased
Is
amount
there
of blood.
Anything we're doing for that?
Well, they usually, if you have a regurgitation, they follow it with echoes, and they, when it gets to a certain point where they think it's going to start to cause enlargement of the heart or damage, then they'll intervene and do a treatment for it, depending on which valve it is. There's different things they
That
can
would
do.
be a valve.
Some sort of surgery.
Sometimes it's a repair,
Yeah.
sometimes it's a replacement.
Right.
They have all sorts of new things that they can do for
And-
valves now.
And the idea is to keep monitoring it.
Yes, that's right. That's right. And let your doctor know if you have a change in symptoms, because if you're starting to get short of breath and more fatigued, go and tell them, because that could be a sign that they need to do another echo and check and see what's going on. Yeah,
Exactly.
good question. Was there any other question? All right, so you can intervene in those two places. You can also intervene in the symptoms. So if you have heart failure and you're having shortness of breath and you're getting fluid overload, there's a number of water pills or diuretics that can help get that extra, and the SGLT2 inhibitors can also help get that extra fluid off. Okay. So that's if you have heart failure, but how to prevent heart failure. So we've already talked about all this. So you want to do all the things to manage any of the things that could cause heart failure. So manage your diabetes, maintain healthy blood glucose, know what your hemoglobin A1C is. Ask your doctor, are my blood sugars normal? Be proactive about these things. If you have thyroid disease, make sure that you're on the correct level of medicine, because those can change kind of, quickly. Sometimes you might not get your thyroid levels checked for a year or two. You kind of forget about it, and you may need more or less of the medicine. So, and that over time, just having your thyroid be not under good control can cause heart failure. Maintain a healthy body weight. We've already talked about being aware of any heart arrhythmias and having those managed. If you've had blockages in your coronary arteries, or if you've had a heart attack, that's not the end of the story. You want to get good follow-up. You want to see your cardiologist regularly. Make sure you're getting the testing done to test, if they want to do a follow-up, echocardiogram, get those things done so that you can kind of take charge. Manage your cholesterol and triglyceride levels. Don't let it go years before you get your numbers checked, because those things can change. We already talked about, treating sleep apnea, getting diagnosed with sleep apnea if you have that, because that's something that can cause heart failure. So you can easily, get diagnosed with that. Whereas CPAP machine, and now CPAP machines used to be these big things, and they made all this noise, and it was whole commotion. They had to carry around a suitcase. Now they're just little. They hardly make any noise. very easy to use, much better than they used to be. Stop smoking if you're smoking. And of course, maintain a healthy blood pressure and avoid heart toxins. I'm going to talk just a little bit more about blood pressure and heart toxins. So they're always changing, you know, what is a good blood pressure. And I like this particular slide because I was going to zoom in on it, but the little zoom thing is gone now. But I circled the important part right here. So, you know, your target, if you're 65 to 79 or greater than 80 years old, is the top number should be 130 to 139, and the bottom number should be, you know, less than 80. So that's just a general idea. Now the numbers change a little bit, just a little bit, if you also have diabetes, if you also have kidney problems, coronary artery disease, stroke, but pretty much that's the number, you know, 130 to 138, and then the top number should be less than 80. So I just trying to keep it simple with the blood pressure. Now, having said that, there's all sorts of reasons that your blood pressure could be lower than that. So if you're on certain medicines for heart failure, they want to get your blood pressure. A lot of the medicines will make your blood pressure go really low, and you maybe even feel a little bit dizzy sometimes from those medicines. But when they're getting to those levels, they're probably at a high enough dose where it's going to have that positive effect on your heart muscle. There are some other reasons why your doctor may want your blood pressure to run a little bit higher than that's also. So, but that's just, it gives you a general idea of what I mean when I'm talking about managing your blood pressure. So high blood pressure and risk of heart failure. Men with high blood pressure have a 2 times greater risk of developing heart failure. Women with high blood pressure have a 3 times greater risk of developing heart failure. So greater risk in women. It's so great that they've started studying women now like that. We used to be invisible. Now they're starting to study us. They did a study looking at people that had heart failure, and 75% of those with heart failure had pre-existing high blood pressure, 75%. So there is an association there between heart failure and blood pressure, high blood pressure. So avoiding heart toxins, and I specifically just wanted to put some information about alcohol. The American Heart Association does not recommend alcohol intake for heart disease prevention. So that whole thing that we keep dragging through, that we have to drink wine in order to prevent, you know, coronary artery disease, has been, continues to not be true. But if you are going to drink alcohol, no more than 1 to 2 drinks a day for men, no more than 1 drink a day for women. And a drink is equal, alcoholic drink is equal to 4 ounces of wine, which is not a cup. It's just not much. Might as well not have it. 12 ounces of beer, or, you know, 1 to 1.5 ounces of hard liquor. And if you have heart failure, it's generally not recommended that you drink at all, because alcohol is considered a direct toxin to the heart muscle. And some people it affects more than others. We're not sure why some people have more of an effect than other people. But anyway, talk to your doctor about that if you do. What? You wouldn't really know. The only way to know is if you had, I have had this with patients where they weren't drinking all that much, you know, maybe a couple, you know, 1 or 2 drinks a night, but they were kind of consistently having wine, you know, and there really wasn't a good cause for their heart failure. And we asked them to try an experiment and just go off the alcohol, and their heart failure improved. So that's how you know. I don't know. It's just something to, you know, if there's not apparent why you have heart failure and not sure why and you're drinking, it's because some people are their heart's very sensitive to, it's considered a toxin. Some people not so sensitive. So it's something to consider, you know, and try a little experiment yourself even. So other heart toxins are, we talked about this already, methamphetamine, cocaine, ecstasy, chemotherapy, radiation, and cigarette smoking. And vaping is just as bad as cigarette smoking.
Because the people that do it use that as
They think it's better. Yeah. And it's not better. It's actually worse because you can vape almost anywhere. With cigarette smoking, it's a whole production, you know, and people are annoyed that you're smoking. But with vaping, you got it right in your pocket. Go right in the bathroom, do it in 2 seconds. Yeah. Yeah. So yeah, vaping is just as bad. So let's talk about a positive thing, exercise. And I know you guys all know about exercise, so I'm gonna make you all feel good for being here because there's no question about it that exercise is helpful. Just to start out, with some general things about exercise. Of course, there's study after study that shows it works for treating depression and anxiety. For mild and moderate depression and anxiety, exercise seems to work as well as taking medications. It reduces your risk of having a heart attack, stroke, and heart failure. So reduces your risk of having heart failure. So look what you guys all did today. Reduced your risk. Increases your strength, your endurance, your flexibility, and balance. So it's less likely you're going to injure yourself in some other way. Helps you get back to doing the things that you want to do in life, the things that you value. Assists in reducing and managing your blood pressure. Exercise all by itself helps manage blood pressure, weight, and cholesterol levels. So good thing. But in terms of heart failure, I put a couple, there's many studies, but I put a couple down here. A California men's health study showed lower physical activity and more sedentary time is associated with higher risk of heart failure. This is published in Circulation in 2015. And then 2 positive studies about heart failure in both the Physicians' Health Study, which is a big study that gets referred to a lot, and the Women's Health Initiative. A moderate level of physical activity, and we'll talk about what that is, was one of the several healthy lifestyle factors associated with a lower risk of heart failure. So, and for those who do have heart failure, there was an action trial that was published in the Journal of the American Medical Association. People with heart failure who exercise first, when they were putting up guidelines for heart failure, they were a little bit unclear and nebulous about exercise, but now we know for sure that exercise is helpful and Medicare will pay for it now in cardiac rehab. People with heart failure who exercise for about 2 hours a week on top of optimal treatment, which means on top of taking the medicines that have been prescribed to you for heart failure, may decrease their chance of dying and decrease their hospitalizations for heart failure. So huge, huge addition there.
Is there a certain age or like the heart itself, does it continue to rebuild the tissue around it, even though it's 70? Is there like a certain cutoff point that is vary on individuals, or does the muscle itself, build tissue? I know it has that capability because I've seen it myself where it's built new arteries on the heart. Although I have one main artery that's blocked and they can't per se do nothing.
Yes.
To it unless they crack me open. But
You're talking about the muscle though.
yeah, the muscle.
So that's a good question. If you've had a heart attack, which means that you've had a lack of blood and oxygen to a part of your heart muscle, you can sometimes, if you get help quickly, you won't get much damage there. So there'll just be a little spot that's damaged and has scar tissue and it's not moving. But if you have a larger spot and it's really called scar tissue does not change. Scar tissue is scar tissue. It doesn't change into muscle. It just kind of gets pulled along with the good muscle. It's not going to contract. It's just going to get pulled along. So no, you cannot do anything about regenerating new muscle over scar tissue in your heart. You can develop, which is different, what's called, if you have a blockage in a coronary artery, sometimes depending on where the blockage is and kind of your anatomy and physiology, you can develop what's called collateral circulation. So you can develop arteries that go around the blocked coronary artery and bring blood supply. But if you're bringing blood supply to a big piece of scar tissue, that scar tissue is not going to develop muscle. It's not going to move well.
I'm just thinking along the lines where you exercise, like curling more and the biceps, triceps, that they get larger. If you exercise hard enough, is it that the muscle will strengthen and produce more tissue?
Well, yeah. So that's it's called concentric hypertrophy. So there is some enlargement of the heart muscle. So exercise in general can cause some enlargement of the heart muscle, so improvement in its ability, its strength. So that does happen. But the main thing, even in somebody who has really a lot of damage to their heart, and there's really not much you can do to strengthen that muscle. The main thing that happens when you exercise is outside of the heart. It's called peripheral adaptation. So you get a little bit of adaptation in the heart muscle, but most of the adaptation occurs in all the blood vessels and the lining of the coronary arteries and all that. So you get really efficient. So when the blood, when you're not trained well, when you haven't been exercising, the blood and the oxygen go whipping by, and the muscles are not very efficient at pulling out the oxygen and utilizing it. You don't have very much mitochondria, so you can't process energy very well. But when you're trained, like you all are, when the blood goes by, your body and your muscles are really efficient. They have more capillaries, they've got more mitochondria, they've gotten maybe a little bit bigger. So you're really efficient at pulling out that oxygen and utilizing energy and oxygen. And so exercise and, walking to your car, walking upstairs feels 100% easier, number one. Number two, it puts less strain and stress on your heart because your body is so darn efficient. Yeah, it doesn't have to work as hard. So, don't just think just because I've had patients with really bad heart failure and not much muscle and they think, well, there's not much I can do, but absolutely. I mean, you can improve so much and feel so much better from doing exercise.
Thank you.
Okay, so type of exercise. Of course, we've been talking about cardiovascular conditioning, sometimes also called aerobic exercise. So that's things like walking, biking, rowing, using the elliptical, the new step, tennis, now pickleball. Anybody play pickleball now? It's the new thing. Stairmaster, gardening, swimming, even chair aerobics, where you're sitting in a chair and you're just moving your muscles. You're putting your legs up and down. You're watching television. You're, doing stuff while you're watching television. So of course, those things have been known for a long time to reduce your risk of having a heart attack or stroke and improve your cardiovascular system. But recently, and it's been, more and more, and I think Linda's actually got a whole lecture on this, don't you? Strength training also has found to reduce your risk of having a heart attack or stroke. So, and it's recommended now as a recommendation for patients with heart failure is to also do strength training. So what's strength training? That's using the dumbbells like Linda was doing back there, also using elastic bands where you're doing, triceps extensions or doing things with your legs, using some of the weight machines. You can also just do body weight activities, right? So that's things like just using your own body weight. If you're not home or you're just doing squats, so you're practicing getting in and out of a chair, you're leaning against a table and doing push-ups or against a wall, using your body as your weight to do activities. So those are all considered strength training activities. So the European Society of Cardiology, which sets standards, recommends both aerobic conditioning and strength training conditioning for individuals with heart failure. So you've got the go-ahead for strength training.
The CDC recommendation too. 2 days a week.
CDC. I'm not going to go through this whole thing. So aerobic exercise, which is the cardiovascular training on the machines and walking, how often, how much, how hard. I know you guys know all this because Linda's drilled it into your head. Let me know if you do anything differently than this. So it's recommended 5 or more days a week for 30 minutes each session at a moderate level. So, when you're first starting, you start with a length of time. You don't just start out with 30 minutes. A length of time you feel comfortable with, and increase by 1 to 2 minutes every couple of days until you reach 30 minutes. Some people may not reach 30 minutes, and it's all incremental. Every little bit of your exercise that you do helps reduce your risk. So even if you're only doing 10 minutes a day, you're just walking around your kitchen table for 10 minutes, even that reduces your risk of cardiovascular disease. Slowly build it to 30 minutes. You can split these into different activities. So you could do 15 minutes on the Stairmaster, 15 minutes on the new step. You could even split it into 3 if that's what you like. It doesn't have to all be the same machine or the same type of activity. Moderate means it should feel somewhat hard. So that means you'll be just a little bit short of breath, but you still be able to carry on a conversation. You won't be so out of breath that you can't talk, but you won't be not working hard enough that you're just sitting like this. You can talk and you can read a book, and you're not working hard enough if you can do that. Linda may have also given you a target heart rate, which in general is 64 to 70% of your age predicted maximal heart rate, or you may have had a stress test where she's figured out your target heart rate. So strength training How often, how much, how hard? 2 to 3 times a week. If you could just get 2 in, that's great. Just a little bit of strength training. 12 to 15 repetitions. A repetition is that's 1, that's 2. Use weight. You can use weight machines. You could use free weights, which are the dumbbells, elastic bands, your body weight. Train the front and back of major muscle groups. So what does that mean? So, train your chest, your back, your biceps, your triceps, your leg muscles, the fronts, your quadriceps, the back, your hamstrings. Those are the major, and your hips are big ones too, your glutes. If you experience severe shortness of breath, of course, you should be short of breath, a little short of breath when you're working out, but severe shortness of breath, especially if it doesn't go away quickly when you finish exercising, you have dizziness, chest pain or pressure, nausea, excessive fatigue, stop the exercise. Don't push yourself, and let Linda know, or, if you're on your own, tell your doctor that you're having these kind of symptoms. Exactly what you tried to do. And just a little note on medication, since we're talking about prevention, take your medications as instructed. I know sometimes medications can give you side effects, or it feels like they're giving you these horrible side effects. Sometimes the side effects, especially if you have heart failure already, the side effects that you're feeling are really just the symptoms of heart failure. But sometimes we think, oh, it's the medicine that's doing this. And sometimes it is the medicine, and sometimes there's a similar medicine that can do the same thing, that it has a different name. So never just quit taking your medicine. Of course, always talk to your doctor, work with them to get everything kind of settled out right, so that you can be on the right medicines to either prevent heart disease and heart failure, or to improve your heart failure. Medications are the key to better managing conditions that cause heart failure. So medications are key, sometimes in managing blood pressure, diabetes, heart arrhythmias. And the important thing, and this is for me too, try to understand and see the connection between the medicine you're taking and any improvements that you see in your health. Because once you see that connection, then you're more likely to take that medicine and not to forget to get it refilled. And all those things can lead you on this downward spiral. And if you don't see the connections between your medicine and feeling better, definitely talk to your doctor or your healthcare provider about that. Work through that with them, because that's the important key, I think, to really doing a good job taking your medicines. So start today. Every day is a fresh day. It's never too late, too early to invest in your heart health, to do the things, some of the things we've talked about today. When we take care of our hearts, we reduce our risk for heart disease and heart failure, and make yourself a priority, like y'all did today, for being here. So thank you.
Thank you.
Yeah. So any questions?
Thank you. Thank you, Sharon.
We kind of asked them as we went along. If you think of something later, Linda can send me a email.
Anybody out there in Zoom land have a question?
Can you hear me?
Thank you, Sharon. That's perfect. Paul, you gonna say something?
Oh, you could hear. Okay, not now, but earlier I was trying to, but
I see your
I guess
name, but I don't hear you.
oh, yeah,
You can
I don't know why.
John thinks you're making a sandwich.
He probably went off to exercise.
No.
Right?
I don't know.
He's probably doing squats.
No, I for some reason I can't.
No, thank you, Sharon. That was great.
You're welcome. That's fun. Nice to see you all.
Thank you, Sharon.
Some new faces here.
Percentage was for the contraction.
Yeah. Like the normal ejection fraction.
Ejection.
Normal is around 60%, 65. Even, there's if it's 40% or less, you're considered to have, reduced ejection fraction heart failure.
I just happened to do a test, and that word was in the thing, so I looked up the test results.
Oh,
See,
just now?
And what was yours?
57.
Yeah.
Nice. That's good. So there's, if it's anywhere between 40 or less is considered heart failure with reduced ejection fraction. If it's anywhere between 40 and 50, it's kind of this little gray zone, but they are starting to treat a little bit in that area, but you're way above that. So you're good.
Yeah, and I did have, when they put a stent in, I had another blood vessel that was blocked.
Uh-huh.
They said
it had napped around it, so they thought that the blockage had occurred a long time ago.
Oh, and you had collateral, you had new circulation around it. Yeah.
So it actually did remap it.
Yeah, sometimes
they-
that'll happen,
They didn't bother to treat that.
right? Because you had good blood flow to it.
Right.
Yeah, good. That was lucky.
So Zoom people,
I
I
have
guess
a-
if you
I
have
have a
questions, you
question.
should put them in the chat, because you're not, your voices aren't.
Have
coming
you,
through.
have you always exercised?
No.
No.
I was very active until I started working in management, then I became more sedentary.
Yes, work will do that to you, huh?
Yeah,
Yeah,
it led to a bad back and other issues.
right.
But, you know, I have family history of heart problems, so I knew it was coming.
Yeah.
So you stay to exercise or not?
Well, thank you all for being here and all the great questions. And Linda's gonna give you a copy of the medicines that we were talking